Hello, we will be doing shoulder abduction range of motion testing here today. So to start, we have our patient in supine. If our patient was unable to be in a supine position, there is an alternative in which the patient would be seated, but our patient here is able to be supine. So we are going to go ahead and continue with this range of motion. So what we're gonna do first is show our patient Emily here how to do the movement. So we are going to passively take her through so that she is able to reproduce that movement actively whenever we ask her to. So Emily, I'm gonna just show you what this shoulder abduction feels like. All right. And now what we are going to do is get our goniometer lined up so that we can measure her range of motion. And for this, we have the stationary arm at the mid-axillary line, or this is also just parallel to the sternum. And then for our axis of rotation, we have the acromion, and this is more the anterior portion of the acromion. And then for our moving arm, we have the medial epicondyle, which for Emily, this is a little bit further out than 0. So we do want to go ahead and measure the starting position so that we are able to get that documented whenever we finish the test. So Emily's starting position is at, gotta get that flipped so that my stationary arm is the right one. All right. We have the mid-axillary line, acromion as our axis, and our moving arm at the medial epicondyle. And Emily's starting position is at about 6 degrees. So Emily, I'm gonna go ahead and place my hand underneath you so that I can feel for any thoracic extension during this movement, and that's something that we want to avoid. As a compensation, but go ahead and Emily, go move through that range of motion. All right, and then we'll get our goniometer reset up. So that is the stationary arm parallel to the sternum at about the mid-axillary line. And our axis of rotation is going to be where that acromion was. And then our moving arm, we're gonna move to the medial epicondyle. And Emily has a little bit greater than the 180, and she is at 185 for her range of motion. So we can have Emily return to normal. So the normal range of motion for shoulder abduction is 0 to 180, and for Emily's we had 6 to 185, so we do want to make sure to document both of those positions. And now that we have that done, we can go ahead and put her back into that passive range of motion to feel for her infeel. All right, and Emily has a nice firm infeel, which is what we would expect with that shoulder abduction, and that is due to a soft tissue stretch of the articular capsule, the muscles, and the ligaments that are in the shoulder. All right, and that is all. All right, hello, I'm going to be testing the forearm supination here today with our patient, Emily. So what I'm gonna do first is have Emily start with her arm pronated, and I'm going to passively put her into supination just so she knows what movement we are going to be doing. So that is supination. All right, and then now what I'm going to do is I'm going to palpate for that supinator muscle while she actively goes through the range of motion. And that attaches at the lateral epicondyle, so I'm able to feel that contraction, and we can go ahead and get set up for the MMT. So for the MMT, our stabilization is at the olecranon process, and medially I will be holding her arm, and then I'm going to have her go into supination, and then I will place my thumb on the radius and my hand around, and then I'm going to have Emily hold strong while I will try to force her arm into pronation. All right, so Emily, hold strong, don't let me move you. All right, and Emily was able to hold her arm in supination with maximal force, so she would get a 5. So if Emily was unable to go through that full range of motion during our screening, what we could have done is put her into the gravity eliminated position, which would be, Emily, I'm gonna have you come over here to this stool. And since we're just doing a quick little demonstration of what the position would be, ideally the table would be a bit higher, but we would just have her arm in pronation here with her elbow flexed at 90, but rested on the table. All right, and that's it. And we would want to make sure to test bilaterally. All right, hello. We are going to be testing our sensory light touch today, and we are testing the C7 dermatome. So on the palmar side of the hand, this goes over digits 2 through 4, and it goes down here and funnels down to the wrist to about there. And then on the back side of our hand, or the dorsal side of our hand, that goes still from digits 2 through 4, and that funnels the sensory cutaneous sensation funnels down further down the forearm to about there, mid-proximal forearm, and that is where we can expect to have C7 sensation. And with the C7 dermatome, the specific testing site, like the point that we typically want to start with, is at the fingertip. And since we are doing light touch, this is a test for the anterolateral spinothalamic non-discriminative sensation. So our patient is currently seated. Another option that is good for sensory can be supine, but we do want them in one of those two positions if we are able. And we are going to start by showing our patient what the sensation is going to feel like and what is expected of them during the procedure. So this is our patient, Emily, and to start off, I will show her a example of the sensation somewhere that is not along that C7 dermatome, since that is the only one we are testing. So somewhere that I can start with would be like the upper lateral brachium, and that is what the sensation feels like. And it's important to make sure that we know that this is a touch, not a swipe. So Emily, what I'm going to have you do is put your arms up facing like this, supinated, and I'm going to have you close your close your eyes, and I'm going to give you a touch on both of your hands, and you're going to tell me where you are feeling this, whether that sensation was the same or different, and if you are able, tell me where that feeling was.
It feels the same, and both touches were on my index fingers.
All right, and since she had a normal sensation, we would rate that as 2, and if we were to have an abnormal response to sensation or differences contralaterally, we would continue to test within that dermatome, starting from the most affected, which would be at that testing point site, and increasing our radius until we are able to get a normal sensation. All right, and that is all for our C7 dermatome. All right, today I will be testing the deep tendon reflex for C7. This is the triceps reflex. So first I am going to ask our lovely patient, Camden here, if he's ever had any reflex testing done. Have you ever had any reflex testing done?
No.
Okay, well I'm gonna go ahead and show you what the reflex hammer feels like, just so that you're prepared. Go ahead. Does that feel all right?
Yep.
All right, so what we're gonna do is now continue with the test. So since this is the triceps test, we are going to start by finding the triceps tendon. So what I'm gonna bring Camden's arm out here and have him extend his arm, and then I'm gonna apply pressure and palpate for the triceps tendon. So go ahead and hold strong, don't let me move you. All right, and then we have it. Then I'm going to support the arm, and remember where that triceps tendon was located at, and then I will go ahead and hit the reflex, but make sure not to let him know when that is going to happen so that we can hopefully get a correct response. And there we go. And we had a muscle contraction at the triceps and a slight jerk to the arm at that joint in the elbow. So for that, we would give him a 2, and we would want to make sure to test the other arm to see if that is normal for him, or to be able to compare the two and whether or not the ratings are accurate and what those ratings would actually mean. You need both sides. All right, and that'll be it.